Thanks for having me today. I'd like to talk to you about something that's been of my interest for the last few years, which is the use of multiplexing immunohistochemical staining and immunofluorescence, both when it comes to using this in clinical practice and also research. And these are two areas which are moving closer and closer together. So I think now's the time to ask ourselves the question, can we actually introduce this multiplexing technique into our daily clinical practice and help us in making the pathological diagnosis? So as has been introduced, I'm a thoracic pathologist in Rotterdam. So I deal with both oncological thoracic pathology and non-oncological thoracic pathology. And I think both would actually, to some extent, already benefit from the introduction of multiplex immunohistochemistry and immunofluorescence in clinical practice and routine diagnosis. These are my disclosures. So if we think about multiplexing methods, I think we can define them as anything that can simultaneously demonstrate the presence of proteins in tissue, up from 3 markers to now up to 100 markers in the same slide. Of course, there are different levels of complexity, and there are also many different methods of actually achieving this. So classically, when we look at the techniques which can be used to stain many markers at the same time, we can look at fluorescence-based methods, which are here depicted at the top, which can deal with the FFP material that we routinely use in diagnostics, but also frozen material, or perhaps even adherent cells in cell culture. And by using a secondary antibody, you can actually visualize the binding of the primary antibody and use a fluorescent tag to then visualize under the respective microscope. This can also be done by using an antibody which is conjugated to oligonucleotides and achieving very much the same sort of image, but in that case you could use up to more than 50 biomarkers at the same time. So another technique to actually achieve this high multiplexing or high number multiplexing technique would be mass spectrometry based methods, which could be cytoph imaging mass cytometry or multiplexed ion beam type imaging. And all of these techniques are actually described in this very interesting paper, which gives a very nice review of all of these different approaches to multiplexing. These are then conjugated with metal isotopes in both cases. And by using the cytoph technology, you can then image those in one slide with sometimes a slightly less in the way of resolution than the classical immunofluorescence techniques. Something which has risen over the recent few years is also in multiplexing using chromogenic methods. You can either do that by stain erasing, so you stain a slide, then image the slide, and then bleach the slide again, and then stain again with a new antibody, and then building up this picture of the slide over the various different stain cycles. You could also do that, and this is something that we've been using over the last couple of years, by using different antibodies with HRP, and then staining with different chromogens, but with a heat deactivation step in between. So you can actually build up a single picture of one slide without the need for imaging in between. Using these techniques, you can not achieve the sort of high numerical multiplexing techniques that you can with multiplex ion beam imaging or with imaging mass cytometry, where multiplex ion beam is based on the technique where you can actually shine an ion beam onto these metal labeled antibodies, which you can see here on the left, and then by detecting them by an ion detector or a time of flight detector, you can build up a picture of per surface area of all the various metals which are present, and then build up the picture as you go along the slide. Imaging mass cytometry is slightly different in that you use laser ablation. You basically burn off all of the antibody, including the metal ions, and then again by time of flight you can detect these and build up a similar picture in very much the same way. Now all of these techniques have their advantages and drawbacks, and again these are very nicely depicted in this paper. I won't go through all of them. Suffice to say that, as I already alluded to, the multiplexed immunohistochemical technique is in our hands, as we're used to these types of techniques and antibodies, a very practical method, but unfortunately it doesn't allow to use more than 5 to 10 labeled antibodies per slide, depending on the technique you use. Whereas on the other end of the spectrum, using the mass cytometry type approaches, you can use up to more than 50 antibodies at a time, but this tends to be quite difficult for a routine laboratory. It's not a routine technique to use. It tends to be expensive, and sometimes you're also limited by the field of view of this technique or the area of interest that you can actually investigate. So I think these techniques, while they're very interesting for an exploratory setting, at the moment are probably not the most advantageous to use in a routine diagnostic setting. Then there are some common multiplex immunotechniques and platforms which will also be discussed today. So for instance, the Milan technique, where you can use up to 30 different staining, scanning and stripping cycles, reaching up to more than 100 antibodies for a particular staining procedure. Something that we also have in-house is the nanostring GeoMax digital spatial profiling platform using fluorescent tags with up to 96 targets. Based on imaging mass cytometry is the Hyperion system with 4 to 37 protein markers, and something that I'm sure is also going to be discussed today is the opal chemistry and spectral unmixing that you can do with that, and with up to 7 targets. And something that we've been using mainly in a routine diagnostic setting is a Roche discovery system where we use sequential heat deactivated chromogenic staining, in which case we're actually limited to a 5-plex stain. So for all of these different techniques, I think it's important to not forget that these are, of course, combinations of individual stains. So it's always important to actually go through a process of validation of the various antibodies, which are then eventually included to come to the multiplexing imaging by using them in a single-plex approach to see whether they actually perform as well as you would expect from any single-plex stain. So that's something that goes for all of these different techniques. So why would we be interested in multiplex immunotechniques in routine diagnostic pathology? Well, I think one of the main purposes could be an ease of use case, or a convenience of using different types of stains in one slide. This could be reciprocal staining patterns, or perhaps complementary staining patterns. We'll see that in a second. Something else that could be interesting would be to use these methods in a setting where we have very little material available, and increasingly with this very little material we also have to do molecular techniques, so it would be very useful for tissue preservation if you only needed one section to do this stain on rather than multiple sections as we routinely do at the moment. So that's important for the tissue stewardship role that we also have as pathologists. Make sure that we use it in the most correct manner. And something else that we could do with multiplexing would be layered analysis, where you stain a particular population of cells and then look for expression of a particular other target within that specific population. These are sometimes very difficult to identify just by the morphology alone, something that we'll have a look at. Spatial information in one slide can be very important and can hold a lot of information as to, for instance, the invasive pattern of various cancers. By combining different stains, we can do cellular subphenotyping in a single slide. That's also very interesting, particularly also, for instance, for our hematopathological colleagues who then don't need to look at different levels and then try to combine the various stains into one phenotype. Increasingly, we could also use various different stains to molecularly characterize a tumor if we know what the underlying potential molecular alteration is. And something that undoubtedly today will also be discussed is the analysis of complex cellular interactions and infiltration, particularly in the context of immuno-oncology. And that will also require automated quantification and deep learning approaches, which is something that I'll only just briefly touch upon and which I no doubt will also be discussed today in later talks. So for a very simple ease of use case, we can look at something that has had the attention of our laboratory, which is oral dysplasia, in which patients who have a normally developing oral surface, epithelial surface, will have a normal expression of these cytokeratins, whereas if you then have differing degrees of dysplasia, you can see that there's an increase in the expression of CK14. So if you combine those two, you actually have a very nice reciprocal pattern, and you can make an estimate as to whether this is actually a true phenotype, because you have that additional information in that single slide. That is actually important because if you have a surface area which does not display any morphological dysplasia, and it is also positive for CK13, that has a very good prognosis, whereas if you have a patient who does not display obvious dysplasia, but you have loss of CK13, the prognosis is worse. So this is actually something that has important prognostic implications, and you can actually integrate that into this flow scheme where you can include the CK13 staining into your decision tree as to whether these patients should be followed up, or you could intensify the follow-up. Something very similar can also be done in the context of vulvar intraepithelial neoplasia, where also you can combine these CK13 stains or CK17 stains with, for instance, proliferation markers such as MIB1, providing additional information. Something that, as a thoracic pathologist, has my particular interest is tissue preservation in the context of small biopsies or cytology of lung cancer, because nowadays we have to do quite a few tests to actually provide a predictive profile for these tumors. So if you are dealing with a squamous carcinoma, you can sometimes get away with just doing a PD-L1 stain to see whether these patients actually qualify for immune oncology, or whether they are treated by chemotherapy alone. Sometimes in never or light smokers or younger patients, you may also want to add additional molecular profiling, which is routine, in fact, in the non-squamous cell carcinoma. So there's an increasing list of different predictive markers that we need to ascertain in these often very small biopsies. And that's based, for instance, in the case of PD-L1, now on quite a large number of different clinical studies which have proven the efficacy of PD-L1 as a predictive marker for immunotherapy. So the tissue preservation protocol prescribes that you try to do as little as possible prior to doing all this predictive testing, and that would also include the use of immunohistochemical markers which you need to identify the different subtypes of small cell carcinoma that we know in clinical practice, so the squamous cell carcinoma versus the non-squames mainly. And routinely we would do that by single immunohistochemical stains. However, that's also possible to combine in a multiplexing technique. For instance, in this case, we have a cytological preparation here on the left in the H&E stain. On the right, you can see that TTF1 stains the nuclei, and then napsin stains the cytoplasm of this adenocarcinoma of the lung. So that's something that we routinely use. Admittedly, these are, of course, only two markers at the moment. You can also do that in small biopsies with very much the same result. So here you can confirm that's an adenocarcinoma of the lung without having to do two separate stains. You can add in a different stain to that to see whether you can actually also exclude any squamous cell differentiation. So something else that's interesting to us when it comes to using multiplexing in the routine setting would be layered analysis. So in this case, for instance, we're interested in the proliferation rate of the epithelium in this slide, and not so much the proliferation which is happening outside of the epithelium. So here you can see in red the pankeratin stain, whereas in the brown you can see the Ki67 stain. So that would be much easier to actually interpret and do the counting of these stains. Something that we've also used in layered analysis is the analysis of a lymph node in this very topical case of a COVID-19 patient who, by using the H&E, was suspicious of having had a lymphohistiocytosis. And here we used a multiplexing technique where we used a CD68 and in this case a CD3 stain in the middle at the bottom, and an MPO stain in blue at the right bottom picture here, where we can see that you can see inclusion of both T cells and granulocytes in these macrophages, and thereby proving that in fact we're dealing with this HLA type disorder in COVID-19 in this case. Going back to immuno-oncology, you can also appreciate here by just using the PD-L1 stain in non-small cell lung cancer on the left, which is staining the epithelial cells, but in a different patient, the epithelial cells are actually negative, but the macrophages are positive, and by morphology alone, particularly to somebody who's not used to looking at non-small cell lung cancer sections, this may be very difficult to distinguish. So it would be good if we could actually combine PD-L1 staining with, for instance, here on the right in pink, the TTF1 stain, and also in yellow, the pan-keratin stain. So here we can see by using this multiplex approach with these three different stains of PD-L1 and also the keratin and TTF1, that this is tumor and this in fact is an area of immune cell infiltration, which by using PD-L1 alone is very difficult to distinguish. So this is a potential application which I think we'll see more and more of in the years to come. Of course, it would be ideal to also combine the pan-keratin stain with a PD-L1 and macrophage stain in a single multiplex method, and that's been shown here. So you can actually determine which cells are tumor cells and which cells are macrophages in just a single slide, and that is also something that can then be used for automated digital analysis. So in this particular biopsy, you can see that there's just a small glandular structure which may be only present in one particular section. So if you do another section, that may be actually cut out of this tissue. So it would be very useful to actually do this particular multiplex stain on that single section to determine that this is in fact an invasive glandular structure, as opposed to the ones which are close to it, which have this intact basal epithelial layer. You could also combine different stains to do cellular subphenotyping in situ in slides, where here, for instance, these cells were stained with CD3, which of course denotes T lymphocytes, but also with CD8, which points towards a cytotoxic phenotype, and CD4, which is a T helper cell phenotype. And then combining those, you can actually define these different populations by combining the different stains. Now, this is a case where we use this type of cellular subphenotyping. So this is a 58-year-old male with lymphadenopathy of unknown origin, and who on a previous EBUS diagnosis was shown to have atypical cells, which were suggestive for non-small cell lung carcinoma. Then the clinicians apparently were unsure as to how to treat this patient, and luckily they decided to do a mediastinoscopy and removed lymph nodes for analysis. That showed the following picture in the H&E stain, where we can see that there's an extensive infiltrate of small lymphocytes, and there's quite a lot of sclerosis. There's the odd eosinophil, and if you see this sort of picture, particularly if there are some larger cells in this infiltrate, you might suggest that this could potentially be a Hodgkin lymphoma, but of course that needs to be confirmed. Then a CD20 stain was done, showing an infiltrate of B lymphocytes and perhaps a few larger cells. CD30 didn't show that much in the way of staining, and these cells were not obviously atypical and not enlarged. CD15 did show a few larger cells with also a paranuclear dot. That's already suspicious. And then PAX5, which might also stain Hodgkin cells was also positive in some of the larger cells, but was not particularly convincing. Interestingly, there was also positivity for EBV. So we couldn't reach a certain diagnosis, and then we decided to use a multiplex immunostain, including CD15, CD20, and CD30, where CD20 is showing all of these pink cells, and then CD15, that's the yellow stain, and CD30 is the green stain surrounding them. You can actually see that CD30 and CD15 co-localize very nicely in these cells, which were then shown to be Hodgkin cells, whereas the surrounding CD20 positive cells are reactive B cells. So we could actually make a confident diagnosis of a classical non-Hodgkin lymphoma in a minute amount of material in this case. You could also use multiplexing for molecular characterization, and this is a case of a cerebral tumor. A 53-year-old female who had a left occipital tumor, suspicious for a glioblastoma multiforme, potentially a metastasis. Molecular diagnosis was done. It was actually diagnosed as a glioblastoma, and then the molecular diagnostic test showed a p53 mutation, NF1, and a variant of unknown significance in NF1, and a complex chromosomal loss with MGMT promoter methylation. And it is known that these tumors with a hypermutated genome sometimes have MMR, also mismatch repair deficiency, and might benefit from microsatellite stability analysis because they do not respond to certain types of treatment which need proficient MMR tumors to actually be effective. So you could actually then in this tumor do staining, and this is the H&E slide, staining for these various MMR proteins, as you would also normally do, for instance, in colon carcinoma, if that's indicated, for instance, for MLH1 and PMS2, where you can see that in this tumor these were still present. But then doing the MSH2 stain and MSH6 stain, you can see that some of the cells do not stain. But this provides you a very complex picture. You don't really know which are the tumor cells, which are the stromal cells in this case. These tumor cells were also positive for p53, but we don't know whether that overlaps with the mismatch repair protein stains. So we then decided to again multiplex and use MSH2, which is seen here in purple, and p53 in yellow. So you see quite a few cells only have the p53 in their nucleus and are lacking MSH2, because if they combine, you actually see that these cells show up as red cells. So by doing that, you can actually show that the tumor cells which are p53 positive are also the ones which lack MSH2. So I've already alluded to immuno-oncology a few times. So we're used to just looking for the absence of checkpoints to predict behavior of a particular tumor to immunotherapy in non-small cell lung cancer. But increasingly, it's also known that intratumoral T cells may play a role. So if you haven't got any T cells, the tumor is unlikely to respond. Maybe you might also need to look at tumor sensitivity or immune effectors such as MHC expression, and also potentially to look at mutational load as a surrogate marker for tumor foreignness. And we've combined these approaches in some of the studies that we've done, and this is a different paper in which, in fact, these authors looked at a meta-analysis of these various techniques as a standalone, and it was seen that by using the multiplex immunohistochemistry approach, you can actually achieve a very good area under the curve with a very good positive and negative predictive values. So this actually outperforms some of the more classical markers that we know, which are predictive for response to immunotherapy. And by combining all of these, you can actually achieve a very good pool specificity. So you can do that by looking at all of these components in isolation. So for instance, looking at exclusion of CD8 cells, again, by using multiplex techniques. We've also done this in small biopsy specimens in a retrospective study in which we looked at various parameters in isolation. So we found that patients who had a very low PD-L1, low CD8 infiltration, low HLA expression, and also a high TML, in this case, do quite badly. Whereas if you have a high TML and a high PD-L1 expression, a high CD8 expression, and presence of HLA, you tend to respond better to immunotherapy. And that is borne out by doing the separate analysis for PD-L1, both for progression-free survival and overall survival. CD8 is not so predictive, and HLA loss by itself is also not predictive. But if you combine all of those and you do unsupervised clustering, you can actually see that by combining all of these positive phenotypes, you can see that these patients have the best survival, both when it comes to progression-free and overall survival. And of course, it would be great if we could combine all of those markers into a single multiplex image, and that's what we've recently done by using PD-L1, cytokeratin, as well as CD8 and markers for immune cells. You can then deconvolute this slide, do additional analysis on this, and actually look for nearest neighbor analysis, for instance, and co-localization, and then combining all of those, you have at least as good a predictive value of response to immunotherapy as when you combine all of those after having done single plex stains. So something that somebody else will talk about today is automated quantification and deep learning. That's necessary for analysis of some of these very complex combined stains. You can use that to segment different types of cells, to classify different areas or different cellular compositions, to quantify, of course, the various different components that you're interested in, but also to do more complex analysis such as nearest neighbor analysis or proximity analysis or infiltration analysis, and eventually also by doing this in an unsupervised way, you could use this for exploratory analysis and actually find out whether there are additional parameters which might be predictive for a specific response to therapy. And there are many approaches to this, which I will not go into at the moment, many platforms and software packages that one could use. So for instance, here we see a slide of a lung cancer where we've stained the cancer for keratin in red and for Ki67 in brown. And then doing this type of analysis, we can actually create sort of a heat map of tumor and proliferative activity, which can be used in the setting that we used it for correlation with PET-CT images. So that's a way to do the analysis. Here are the other types of analysis that I quickly mentioned. So this is the classifier analysis, where you can actually distinguish different areas of a tumor. You can do this nearest neighbor analysis, so to look for differences or to look for distances between different immune cells in a tumor, for instance, which is also done here. And you can look for infiltration of the tumor by immune cells by doing this type of deep learning approach. And then hopefully eventually you could combine all of those approaches and then come up with a predictive model to classify this tumor with. Now, to finish off, I think it's important that all of these steps require, of course, rigid validation. So the pre-processing phase is important. You know, how long do you keep the tissue on formalin for instance? Then the processing stage itself is important, of course, to validate the staining procedure, the analytical phase, and then eventually also the AI algorithms which are trained using all of these images. So all of these need to be validated in your own laboratory, both from a technical point of view, internally, but also potentially also eventually externally, You also have to validate it against the singleplex staining, as I mentioned earlier. So you need to be sure that what you're looking at in multiplex is actually a true representation of the singleplex staining. You also have to perhaps think about validating it against the pathologist assessment. So if you're using these AI approaches, you need to be sure that if you're going to use that in a diagnostic setting, it's at least as good as a pathologist in doing the same sort of assessment. Then you have to make sure, if you do that type of analysis, that the staining consistency is right, that you have a good scanner with the right magnification, which is consistent as well. You have to choose the right analytical software, which can produce consistent results. The settings are important. How big are the areas of interest that you look at, for instance? What type of algorithm do you use? So these are all steps that you need to make decisions about, and which can have implications for use of this type of approach in a routine setting further on. And then last but not least, I think we all require prognostic and predictive validation. So in true patient cohorts, this can be done in a retrospective or a prospective manner, because eventually what counts is that what we do actually has a bearing on the prognosis or prediction for this individual patient. And then, of course, also nowadays, we need to make sure that everything that we do can be integrated into our routine workflow. Is it easy to use? For instance, in our PAC system, are there efficiency gains for the laboratory or the pathologists? So by doing all this, and as I've described in all of the previous slides, I think we can now move from an era in which we were focused on finding that one black sheep in the sea of white sheep to an era in which we want to identify all of these colorful sheep in one single photograph. And as we're moving along this development, I think more and more we can see that this is actually almost ready for clinical practice, although I think that will be in the context of probably the lower end of the number of multiplex stains that you use, rather than the sort of more exploratory analyses with the scores of different antibodies that can be used, for instance, in the cytoph type approaches. So that's almost as colorful as our skyline at night in Rotterdam, and I'd like to thank you for listening, and I'm happy to answer questions.